welcome the board, welcome the fellow students to my complex exam and progress report. My topic is about ACL injuries and its effect on the knee joint. I'm Robert Jonge from the Uzsoki Street Hospital. My vision is to understand the nature of sports injuries, provide better care and life quality for knee-injured patients, and we'd like to achieve this by resolving disagreements and controversies of anterior cruciate ligament injury and therapy. I have two ongoing projects right now. First one is about comparing operative and non-operative treatment, and the second one is adding an anterolateral extra-articular procedure to the ACL reconstruction. So first of all, let's talk about should we operate or not isolated ACL injuries. Rupture of the ACL leads to instability, which is a major risk factor of osteoarthritis, which affects up to 50% of ACL injured patients. In the US, there are more than 130,000 ACLs reconstructed yearly, and in Hungary, more than 305,000 reconstructions were made before the COVID pandemic. Usually, the gold standard is surgical reconstruction, mainly because it's associated with improvements in knee stability and better restoration of activity level, and conservative treatment is reserved as an alternative. However, with a good rehabilitative treatment, dynamic stability can be effectively regained and achieved, as well as it eliminates the risk of surgical complications. And despite this is a well-studied topic of orthopedics, we still do not understand which option is better to potentially prevent knee osteoarthritis. And our aim is to find the best possible practice for this. We have investigated isolated ACL ruptured patients with reconstruction, compared them to conservative treatment, and we were focusing on radiological signs and functional scores. We had more than 13,000 articles, of which only 5 made it to our evaluation. So let's talk about results. On the X-ray, there are clear signs of osteoarthritis, and on every scale that is used, there is a clear cutoff value between normal and abnormal knees with osteoarthritis. So here we can see on our pool results that there is a 1.80 for higher odds to have a normal knee for the non-operated patients, actually, which is quite a new thing and quite surprising, because we associate that with reconstruction we could have more protectiveness in the joint. However, this difference is not significant. Isometry measures the anterior translation of the tibia, comparing the injured and normal extremity. Here we can see that there is a minus 2.44 millimeter mean difference between conservatively and reconstructed patients, which favors reconstruction, and this is significantly better for the reconstructed group. Ligament score is a patient-reported outcome on a scale of 0 to 100. Here there is 2.88 like improvement for the reconstructed knees. However, on a scale to 0 to 100, this is such minimal and not a significant improvement that we have interpreted as clinically not significant difference. Here are the summary. Radiological science favors conservative treatment. Arthrometry is significantly better for the reconstructed knees, and Ligament score was interpreted as clinically not meaningful. Therefore, it favors conservative treatment. Also, we had much more outcomes, but we couldn't analyze it statistically, so we analyzed it qualitatively. We have done the systematic review table of the outcomes, and you can see that in most of them there is no significant difference between the two groups, and just a few that favors the reconstruction. Also, we summarized the subsequent injuries and surgical interventions. In these studies, we can see a slight trend towards reconstruction could be protective. However, in the well-conducted RCTs, there were no surgeries or any other injuries in either the reconstructed or the non-operative group. So the strength of our study is that this is the most comprehensive literature review available until now on this topic. So we hope our findings and suggestions could serve as recommendations for study designs and may affect guidelines in the future. Of course, there are limitations. Like we just had a few studies there were with different outcomes. There were poor data reporting, and we could only include 2 RCTs. As well, ACL reconstruction techniques were heterogeneous in these studies. But our conclusion is that non-operative treatment could also be an option for isolated ACL injured patients. Therefore, we should consider it as a primarily treatment option for this group of people. However, more RCTs are needed with standardized research protocols and with more specific subgroups. So my manuscript is right now in revision at the Orthopedic Journal of Sports Medicine, which is in quite a good position in the orthopedic journals. My second topic is about adding anterolateral extra-articular procedure to the ACL reconstruction. ACL injury is one of the most common knee injuries, and anatomic single bundle reconstruction is the gold standard right now. However, up to 25% of patients experience a residual rotatory instability, which is associated with poorer outcomes. Therefore, anterolateral extra-articular procedures are aiming to reduce this rotatory laxity. And we are trying to find out if this is a superior procedure. We are investigating ACL reconstructed patients plus anterolateral extra-articular procedures, comparing them to reconstruction alone, and focusing on knee stability and graft failure mainly, also functional outcomes. And we think that it could decrease rotatory instability and lead to better outcomes. Clinically, the most important thing would be to reduce the graft failure, also improve knee stability and shorten the time of return to play. We have around 7,000 articles, of which we are expecting around 50 to be in our study. Right now, we are finishing the full text selection, and also we have done some preliminary data extraction. So basically, this is where we are with our 2 topics. Our revision has been submitted early this June. Actually, it's 2023. Sorry, and we hope that our second topic will be submitted this fall, late this year. Some addition and thanks to this program and the support of our hospital. Last week we were able to present our abstract and our study with my fellow colleague Miklos at the ISAKOS Congress in Boston. So thank you for your attention. My motto is the same as always. Only time I set the bar low is for limbo. Thank you very much.
I mean, these are both clinically relevant questions, but why you are, I would say, lucky with your second study, because there are quite a few, I mean, reasonable publications. In the first one, you have only kind of in each forest group, you have any class 2, which is a kind of just at the borderline. I would say that I mean, in my limited understanding of biostatistics, that you can actually make a conclusion. So the question is, I mean, 2 actually. One is whether this is the final word on this. Second, whether your clinical practice is changed based on actually on this data. I mean, so the conservative is actually seems to be equally kind of effective, or not worse than the operative way.
Thank you for your question. Yes, actually, this is our final evaluation on our first topic. Yes, it is really hard to to carry out a good analysis, and of course we can't carry out a robust statistical analysis based only on just like 5 studies that we have included, but also there is the quantitative analysis with the systematic review. I showed those 2 tables with a lot of different outcomes that we also included when we were creating our conclusion, and we have discussed it in the discussion of our manuscript. And actually, yes, this has an effect on my clinical practice, because you can always start with conservative treatment. Also, you have to match the needs of the patient to your decision, and you have to bring the decision together with the patient, like weight and BMI, age, activity, work, lifestyle, and what they would like to do. Therefore, and also the initial instability of the knee. If there is a big instability, it's a young patient who would like to do more sports and would need, especially pivoting sports, then I would recommend to go for a reconstruction. But if it's not a high demand patient with a lower grade of instability and older, then I would say let's try conservative treatment. And even if conservative treatment fails, then we can do the reconstruction at any time.
I would like to ask the Lisholm score in your first topic. How much reliable is it?
So Lisholm score, as I mentioned, it's a patient-reported subjective outcome, which consists of 8 items that measure symptoms and activity as well. And I think it's important to note that it actually measures the field of instability of the patients in quite a significant amount for up to 25 points. Lisholm score is especially for ligament and structural knee injuries. There was a study that measured the reliability of the Lisholm score, and the conclusion was that if there are multiple injuries to the knee joint, like multiple ligaments or meniscus or cartilage lesion, if these are combined, then Lisholm score could be a bit unreliable. There could be more errors in it. But for single structure injuries, like for isolated ACL injuries, it is a quite reliable scoring system.
As you mentioned earlier that you can always start with conservative treatment and proceed with the ACL reconstruction later. I wanted to ask you that is there any negative effect if you postpone surgery? Could it affect the patients negatively?
Actually, we are doing the way that we either operate it acutely or we operate it after 6 weeks. This is because after the first week to the 6th week, if we operate in that time period, there could be arthrofibrosis development of the knee after the operation, so we skip that time. After the 6 weeks, there shouldn't be such a big problem with the operation. Of course, if there is a higher grade of instability, then cartilage degeneration could accelerate, and actually that's what we try to protect. So that should be counted into account when we decide about this.
You have chosen 2 articles. One of them was published 21 years before. So it's an old one because the methodology at that time was totally different from that we use today. I think it's could be a problem. The other thing is you answer the question relating to the age of the patient very properly, in a proper way. It's very clear, but it was not seen on your on your slides. Why is that? You have discussed this in your paper.
it was actually a surprise for us that we could only include 5 articles. So mainly in this topic there are observational and descriptive studies. There are a ton of them, really. But which one in a single study compares both of the treatment options? There are just a few, actually 5 papers. So that was the problem. As you can see, to the full text selection, it made 109 articles, and mainly 104 articles were observational and descriptive studies. That's why we could only include these 5. Yes, about the age, there is a table called which describes the each studies, and in that table it is the age is included. It is in the manuscript. So we talk about the age in our manuscript. Actually, it was there was no high heterogeneity. Patients were in their 20s, 30s, and in 30s, 40s when the operation was done. So these were mainly young and active patients in these studies.
Actually, I haven't heard anything else from my sports surgeons that we have to reconstruct ECL, otherwise the late osteoarthritis accelerating, and what about the patients with high level sport activity? No time. There is no time for conservative treatment, I think. And concerning the late results in osteoarthritis, I'm sure if you do not reconstruct the ECL, the late osteoarthritis is much more severe than with patients in conservative treatment. Have you had any data in late osteoarthritis and with patients with high-level sport activity?
Thank you very much for your question. This is really important. Actually, with high-level athletes, we do not have results. That's why I included here at the implication for research that with specific subgroups like more active patients and elite athletes, studies would be needed. Yes, you have said it right. With high demand and young patients like professional athletes, the first goal is to stabilize the knee. That's why maybe for them the operative treatment would be more beneficial. But at our radiological evaluation, the studies are longer term studies, so it's not like 2, 3, or 5 years. It's around 8 years. So I think we could say that it's a longer term.
I have 2 quick questions for you. First of all, did you look at the, let's say, incidence of ACL reconstruction that has been done in Hungary versus other countries based on the population size? Because this is sometimes people are arguing about the population size and number of injuries and incidence of how many people are operated. Are there too many operated compared to other countries? First question. Second half question is, do we have a number of returning to daily activity compared reconstruction versus non-reconstruction patients?
Thank you for your questions. Actually, we haven't done an epidemiological search on this incidence number between Hungary and other countries, but in my introduction, I have mentioned that in the US, for a population of 350 million people, there are 130,000 ACLs reconstructed in a year, and for like 9.5 million people in Hungary, based on this before COVID pandemic, it's 2019 data. There were 3,500 reconstruction a year. I'm not really good in counting this out real quick.
The biostatisticians should do this by head calculating now, but well, that's a good answer. Yeah, I agree. So it.
Opa.
And the second question?
Second one, about return to play time or return to activity time, there were no data in these articles, but we had data about the Tegner score, which refers to how high level of activity they can return, and there were no significant difference in that.
As mentioned before, you pulled only 2 articles, results from 2 articles. Could it be considered, this pooled effect, as a real summary effect?
This is a hard question, really, because we are only counting from 2 points, which makes the work of the statistician and much harder, and also for us it makes much more harder to interpret these results, if these are true results or these are biased. However, with pooling, we could done this statistics, and we had the results, and also, as I mentioned earlier, we did the systematic review part, compared our results with other meta-analyses, which also includes just a few studies. There was a recently published article in the BGSM. They shows like they had 9 articles, but actually those were only 3 studies and more reports on one population. So basically they worked with 3 articles as well, and they had almost identical results. So I think even this is just 2 studies pooled, the results should be valid.